afternoon and welcome to the MediRegs and Canary Insights webinar entitled Navigating the Coverage Policy Landscape. My name is Ray Ellen Kishbaugh, and I will be doing a little bit of housekeeping up front to make sure that you understand how to attend the webinar today. The handouts are available under the handouts heading on the right-hand side if you want to follow along that way. And your phone line is muted, but you are free to ask questions in the questions panel at any time. Those might be questions specifically for our speaker if you have any additional information that you would like after the webinar. It will for about an hour, and we probably will not have time to take live questions and answers, but we will take the time to get back to you after the webinar is over. So it's my pleasure to introduce you to Patty Telgina. Patty is the Vice President of Reimbursement at Emerson Consultants and Canary Insights. Emerson Consultants is a company focused on offering reimbursement, regulatory, clinical, and market development consulting to the medical device, biologic, and pharmaceutical industries. Currently, Patty is working with numerous medical device, diagnostic, and biologic companies, ranging from startups to multi-billion-dollar organizations. Walters Kluwer and Canary Insights has entered into a partnership agreement where we're able to offer solutions to reimbursement strategists in this life sciences industry. We'll be going through some of the concepts of that in the presentation. Canary Insights is a tool that will help you keep up with private payer policies, and MediRegs Coding Suite is a product that will help you keep up with coding and regulatory and payment and coverage information coming out from the government. So it's my pleasure to be on the phone with you today, Patty, and you can go ahead and get started.
Well, great. Well, thank you, Ray Ellen, and good afternoon or good morning, depending on where you live. And thank you for joining today's webinar sponsored by Canary Insights and MediRegs. As Ray Ellen said, the title for today is Navigating the Coverage Policy Landscape. I always say it could be called Navigating the Coverage Maze. I don't know about you, but it feels like every time you feel like you have it figured out or under control, it changes. But today we are going to be talking about what each of you can do to be successful in this constant changing environment, and also how Canary Insights and MediRegs can provide you the resources that you need to stay on top of commercial, Medicaid, and Medicare coverage decisions. Just a quick overview of Canary Insights. I usually start with the name. Everyone says, why the name? That doesn't seem to be medically related, but it is. Canary Insights comes from when miners would use canaries as an early notification or warning, and that's really what both MediRegs and Canary Insights is doing. We've created a resource that automates this process and sends you alerts should policies, regulation, or payment change that impacts your business. Canary also sends out alerts on CPT panel meetings, fee schedules, payer directory, etc. And you will have a chance to see some of the examples for both MediRegs and Canary Insights at the end of the presentation. So today, we do have 60 minutes. As Ray Ellen said, we may not have a lot of time for questions. If we do not have time to answer all the questions, please know that both Ray Ellen and my contact information will be provided, and we will be able to answer all of your questions following the webinar. So today, we are going to discuss initiatives impacting new technologies, such as payment methodologies, how the coverage landscape is changing. We're going to talk about mergers, consolidation within payers, and most importantly, we're going to talk about how Canary Insights and MediRegs can provide resources that can help you stay on top of this, so you can be proactive rather than reactive. Okay, so slide number 5 here. So let's start with how the incentives for payers and providers are changing. And when providers and payers' incentives change, that means that manufacturers' incentives or value propositions need to change as well. All of us are very familiar with the Affordable Care Act. With the new administration, I think everyone kind of says status and future unknown. But I always say, while there will most likely be changes, there are going to be some things that don't change, that all of us need to be aware of and know how to play within that parameter. For example, price pressure to contain costs is going to continue as there are limited dollars. Another key takeaway that's not going to change is patients will continue to be key in the decision making, maybe even more so under the new administration with health savings accounts or possible higher deductibles. So when you talk about coverage and how health savings accounts or higher deductibles impact coverage, what that may mean is a payer covers your technology, but if that patient is responsible for the first $5,000, that patient may still be paying out of pocket. So having a coverage decision did not necessarily have less out of pocket for that patient. Again, when you're developing your value proposition for your product or your technology, you need to make sure that you are aware of that. Access and affordability with the state mandates, Medicaid expansion, all of that is still to be understood and to be developed under the new administration. Another key component that everyone needs to be aware of, the economic value propositions are changing. So under an integrated system or under an accountable care organization, no longer do you walk in with your fancy coding sheet that has a CPT code with revenue attached to it. Under the new systems, under the new payment methodologies, they're more interested in how to manage cost, taking care of that patient, not necessarily per encounter, but the overall cost to manage that patient. And this is impacting physicians as well as hospitals. Big change with hospitals in both Medicare and commercial is payers are frequently not paying for readmissions within 30 days or no longer paying for conditions that develop while that patient is hospitalized. So again, keep thinking, how does your technology fit within the changes in this system, and how do you create value? We talked about in the last slide about that readmissions and hospital payment changing. Significant changes with how physicians get paid, and that's going to change how you sell to physicians. Overall, we will continue to see, in my opinion, less fee-for-service and really payment based on outcomes. Medicare has really gone as far to say that by 2018, their intent is to have 50% of those Medicare payments tied to alternative payment models. And that alternative payment model encompasses a broad range between MACRA, the other demonstration projects, but what it means is 50% not tied to fee-for-service. Again, lots to change with new administration, but I think the trending here is going to stay. Mm-hmm. So let's talk about how just in general the payer landscape is changing and how that may impact you. First of all, mergers. And I should say maybe potential mergers, but lots going on there. If 4 of the largest payers potentially go down to 2, what does that mean? I say it could be good or bad depending on how you look at it. If you have a positive decision, it will impact more covered lives. But if you get a negative coverage decision, same thing, more covered lives impacted. Another change that we've already seen with some of the mergers is which payer drives the coverage policy. So if you had a positive coverage with Anthem, but negative with Cigna, we've seen that kind of go both ways. So just be aware of that. Same thing on the Medicare side. MACs have consolidated decision making, For those of us that have been around for a long time, we remember the day when really each state had their own carrier and their own medical director. And it was very easy to use the influence of key opinion leaders at that time. You could get a key opinion leader in Illinois who personally knew that Illinois medical director and could push through coverage. That's not the case anymore. So you have 9 decision makers. Medical director may live in Texas, but yet they may still cover Illinois, for example. So less decision makers, to me that says your clinical evidence is going to continue to be more important because your decisions are going to have more impact. Another change from a coverage landscape. Lots going on with Blue Cross Blue Shield Association. I think we've all encountered the internal policies. I like to kind of call them Bigfoot. Everybody knows they exist, but no one can get a copy of them. In my experience, they're almost becoming default national policies. So the state or regional plans don't have to follow them, but there is a compliance condition where state plans need to follow a certain percentage of them. I have heard that compliance is 75%, but again, have not seen that in writing. But where I see this impacting is if there's a negative internal policy, those are very easy for the state and the regional to pick up on. So you start seeing other Blue Cross Blue Shield plans writing the same coverage decisions. If it's positive, it's great. If it's negative, it can make more challenges. Also, my second bullet point here on slide number 9, there's a lot of changes even within the association. They no longer go by tech. They go by the Center for Clinical Effectiveness. Those tech assessments, which used to be in the public domain, are really not anymore. They've had a lot of pushback on some transparency, or should I say lack of transparency. And what they've really kind of come up with is kind of a new subscription service. Some of you may be aware and actually using it. It's called Evidence Street. The good is it does allow some inside access to these policies, and you have an opportunity to submit clinical data directly to the association. However, it is a subscription base, and it does not necessarily come inexpensive. So what we've seen is it's basically the large companies that have multiple products that have access to Evidence Street, and not necessarily reasonable or necessarily cost-effective for some of the smaller one-product companies. But that's a big change, and those tech assessments used to be in the public domain, so that's a change. All right, so we talked about what is changing. Let's talk about who the players are and how some of the decision makers are changing. The elephant in the room is Medicare. I hear from companies, well, we are only in the pediatric space, so I don't really have to worry about Medicare. And I say, oh, you do, because Medicare can influence and does influence commercial payers. And at times, I've seen them write non-coverage. When I say them, I see Medicare writing non-coverage on therapies that are not even used in the Medicare population. So that second bullet point, you have, for Medicare, you have the national coverage decisions and you have the local coverage decisions. But again, on the local level, you're now down to less MACs with larger jurisdictions. From the national and regional payers, there's really over 200 of them. It can be very difficult to stay on top of that many commercial plans. You can have HAYS or HRQ or NICE or ECRI all writing possible coverage statements or technology assessments, and you may not even know about it. Canary, and I know MediRegs, we've sent numerous alerts. In the case of Canary, on draft HRQ reports or HAYS reports that have been published, because you can be assured that your payers are looking at those reports, and it can and will impact your coverage decision. So again, another reason to be aware of resources that can help you stay on top of it. So what is the process? You know, we can say a lot of things about Medicare, but at least I say it is transparent. If they are going to issue either a national coverage decision or a local coverage decision, by law, they have to publish it and allow for comment. Yes, they can some coverage articles, etc., but if they go through the full policy process, they do have to publish it and allow for comments. But the trouble is that you need to be aware that these draft policies are out there in order to comment. And be aware that anyone can request a technology be reviewed for coverage. So just because you didn't request it on your product does not mean it won't get reviewed. And Medicare does allow the draft decisions to be discussed at the open door meeting. And I don't think this is a coincidence, but typically these draft policies are posted typically within 2 weeks of that open door meeting. That does not leave a lot of time to get your speakers, get organized, to attend those meetings. So very important that you are aware when the open door meetings are happening and when you have a potential draft policy being reviewed. And Canary Insight sends alerts on those, trying to give you as much notice as possible. On the commercial side, that's really a lot less transparent than Medicare. Some payers do publish the draft policies. HCSC does, Blue Cross Blue Shield of Alabama, Tennessee, Hawaii. Some of those do publish draft policies, but most do not. Important thing to be aware of, payers, many of them publish either monthly or every other month bulletins, and they will publish information in a bulletin that does not always make it to a policy. And for example, we've seen come in that say that they now require prior authorization, or they must fail XYZ conservative therapies. If that's only in a bulletin and you didn't see that, it's hard to let your providers, your customers, your patients know what needs to be done. You can probably pick up by now that I really appreciate and value transparency in this policy making process. I would say the most transparent is HCSC, which, as you know, is the Blue Cross Blue Shield for Texas, Illinois, New Mexico, Wyoming, and Oklahoma. They have vendor days 3 times a year. You can request to be on that agenda, and you get a chance to present to their full medical director staff. Does not mean you always get them to write positive coverage, but I always say you do get a chance to present your technology in person, and really I do feel that they take an interest and really understand where does this fit within their plan. So is coverage consistent? And that answer is no. High Level Health Affairs published an article in 2015. When they looked at it high level, they felt like commercial covered or followed Medicare about 50% of the time. And then they said Medicare was more restrictive 25% of the time, less restrictive 25%. Basically what that says, takeaway is it's not consistent. But if you have a positive Medicare decision, I always say commercial payers will say their process is different, they don't have to follow Medicare, etc. However, if Medicare gives you a negative LCD, I find the commercial payers are very willing to pick up on the negative coverage decisions. So you need to be playing on both sides. You need to be aware of Medicare, and you need to be aware of the commercial. Another significant change that we're seeing is the level of specificity in coverage policies. And what I mean by that is payers are writing, in many cases, coverage by device. And spinal cord stem, I think, is a good example here. Some would say spinal cord stem is spinal cord stem. But we are seeing payers write policies that say this technology, maybe the high-frequency spinal cord is covered or is not covered, or the stem wave is not covered. So in a broad spinal cord stem policy, they are making decisions as to which products they may or may not cover. Also, my last bullet point here on slide 13 is we're seeing a lot of payers, rather than just say they're not going to cover something, what they're saying is they're going to put a lot more restrictions on coverage. In spine, I would say, is a good example here, that they may cover it, but they're going to require XYZ conservative therapies be done before surgery. So that may delay when a patient may be eligible for a surgery. So what are some other initiatives impacting you and how some of these coverage decisions are made? Durable medical equipment. This really isn't new, but it's impacting a lot of technology because new technology is much more on the mobile app, remote, smaller, not bigger technology. So to fit into Medicare's DME box, Medicare says that you have to have a 3-year expected life. That doesn't allow for new technologies that are disposable or display information on a cell phone. It really is a struggle, and I think CMS is realizing that, but they're still boxed in that you have to meet a category before you can have coverage. And there is a lot of great new technologies that are mobile apps or disposable or do not have a 3-year life that are struggling with Medicare coverage. Now the commercial side, they don't have to follow that, and typically they don't, but Medicare has and has continued to follow that. Another thing, if you are in the DME or the durable medical equipment space, is competitive bidding. Again, not new, so I can't see there's really any changes other than if you are part of competitive bidding, you are probably feeling the pain. Pricing and access to technology has been limited under some of the competitive bidding. So we just have a couple more slides here, and then we're going to get into a little bit more interactive and a little bit more in the demo of what MediRegs and Canary can offer you. So here on slide number 15, ICD-10. In a way, it is completely old news. The world did not end as everyone thought it would. Both providers, payers, hospitals, I think, have all incorporated, and they're certainly accommodating the ICD-10 system. But I like to say it's kind of the gift that keeps on giving. So there are still changes that are happening. As a medical device manufacturer, we're also lab or diagnostic, you need to really understand if your DRG placement changed as a result of ICD-10. Medicare will say that was never the intent, but Ray Ellen, and we'll talk through some examples, that there were some changes under ICD-10 where that DRG went up. It was reassigned to a different DRG, so it may have gone up or it may have gone down. Also, much higher level of specificity within ICD-10 allows coverage criteria to be somewhat more limited by diagnosis. For example, with the insulin pump, in the past, coverage decisions may have just said, you know, patients with diabetes uncontrolled would be eligible for an insulin pump. And that was about as granular as they could get. But now they can really say, before they may want to cover, the next versions of the pump with a low glucose suspend or artificial pancreas, they may say, I want that patient to have documented hypoglycemia or hyperglycemia. And there are now ICD-10 codes that can say if that patient had a hypoglycemic incident. In the past, that payer couldn't, because all they had was a 250, I'm just going to give you an example, of type 1 uncontrolled. So again, not necessarily good or bad, but just be aware that that payer now has a whole new level of coding and specificity to really know what patients have the best outcomes from some of these new technologies.
Hey, Patty, I'd love to just mention a little bit about our experience with the ICD-10 changes and how that's impacted both providers and payers as well as life sciences manufacturers. We saw as ICD-10 implementation was coming a significant drop-off in the number of published coverage determinations. The MACs had to translate all those ICD-9 LCDs to ICD-10 LCDs. They had to update all of their claims edits, and they were consolidating at the same time. So they were instructed that if they were taking over for multiple states, they could choose to be as generous as the most generous state that they were taking over. And so in some cases, they just interpreted that drop writing an LCD. So we've been in this really difficult period for providers and payers. I get both on the phone regularly, where there just is nothing published. So it's an interpretive call on the part of the payer and the provider, and can lead to lots of interesting conversations. So then ICD-10 went live, and I'm guessing the payers have noticed that they're paying for more things that they used to deny. So we're starting to see the volume of local coverage determinations creep up. And that means that there's lots of changes, there's lots of new information, there's a lot going on there. So we've needed access to really understand the ICD coding and the clinical evidence, and now we're going to start to get a little bit more guidance coming out in a written coverage policy. And then also with the I-9 to I-10 translation, a lot of the payers mapped, and we know that all the maps were not complete, that there were gaps and errors and omissions. So there were policies where the narrative discussion around what this particular device should be covered for was quite clear, but the code edits were more narrow than they maybe should have been, and there was a lot of need to correspond back and forth between providers and payers to kind of get that into alignment. So it's been an area of a lot of confusion for payers and providers, and a real need to be able to stay right on top of those changes as soon as they come out. And so, yeah, I agree with you that Medicare said it would be a revenue-neutral decision, but it wasn't a work-neutral decision, and it's created a whole extra conversation for providers and payers around what is covered and what isn't covered. And I don't see that getting easier for the next 3 to 5 years. So it's definitely a time to have access to some way to keep up.
No, that's a great point, Ray Ellen, and I saw a lot of that too, especially while the jurisdictions were kind of being reassigned.
Right.
And so what JH used to cover was different than a different jurisdiction, and then as that MAC consolidated, it really was kind of up in the air which of those policies that they would take. And there were many times ICD-10 diagnoses may be different. And that had significant coverage issues if they no longer covered a diagnosis for one of the most frequently used diagnoses. So that's a great point, and you're right, I think it will continue to evolve.
Mm-hmm.
So I have really two more slides before we get into kind of a little deeper dive of what are all these resources that we kind of keep talking about. But I really want to make sure that everybody understands when you talk about coverage or understanding your coverage landscape, you really have to understand the coding process. And the CPT coding process is not for the faint of heart at all. The process to get a new CPT code or even a new HCPC code can take 12 to 24 months from FDA approval. So common sense will tell you if you have to have FDA approval before you can apply for these codes, you're already behind the 8 ball. So let's talk about kind of CPT coding. If you have not attended an AMA CPT panel meeting, you really should. Even if you don't have one in the pipeline. These meetings are open to the public. They occur 3 times a year. They can be fascinating, and I actually say entertaining, assuming you're not the one sitting at the table asking for a new code and kind of barraged with questions. But anyone in kind of the healthcare field that works with CPT codes should understand this process. There are an increasing number of Category 3 codes, and that really is a big change. 5 years ago, if you got a Category 3 code, it was really the kiss of death. What's happening now, it still can be very challenging, but more and more technologies are getting a Category 3 code many times before FDA approval, because you can get Category 3 before FDA approval, and it can make it easier then to slide into a Category 1. There are coverage issues that you will need to overcome with the Category 3. But the takeaway here is understand, especially if you are a new technology, understand if you're going to need new CPT codes or HCPC codes, understand the pros and cons, understand when you're going to be ready to go for Category 1, and also understand if you need to go for Category 3 or use an unlisted code in the meantime. But new technology, you have 12 to 24 months that you're going to have to figure out how you're going to get your providers paid, or if you are the provider, how you're going to get paid. So we covered a lot of things. Most important is, what can you do? I always try to not just outline the challenges, but then to really focus on what you can do to make sure patients and providers have access to your technology. Number 1, if you don't remember anything else that Ray Allen and I will tell you today, I want you to remember one thing, and that is invest in the clinical data. Regardless of where healthcare reform and all the initiatives we discussed go, what's not changing is you're going to need clinical data that shows improved outcomes. FDA approval will say that you're safe and you are efficacious in what you say you do. It does not get outcomes. I like to tell you an FDA approval or clearance will get you, a ticket to the dance, but it doesn't get you a dance partner. You really need those improved clinical outcomes and have that documented. Start early. Understand the reimbursement landscape. Use the resources that are available to you. You are all working with less staff. When you get a look at what MediRegs and Canary Insights can offer, I say, do you really want your team focused on just tracking these policies, or do you want them focused on impacting the policies? Think outside the box. It's difficult times require difficult measures. I also say it's a time of great opportunity to go to payers and propose pilot programs that are at risk, or go in, and if you don't have all the data that you need right now, can you request coverage for a subset of patients? Type 1, not all patients with diabetes, etc. Stay informed. That's the only way that you can be proactive versus reactive. Okay, so Ray Allen, I think we are very good on time. So we have a couple slides here on specific to how MediRegs can help. And then we have a couple slides on other resources that participants can have. And then a little bit more on how some very specific things with Canary may also help them.
Thank you. So we spend a lot of time with our customers at the Coding Suite helping both providers and payers as well as device manufacturers understand how to get paid. And that's based on a lot of issuances from Medicare. When it comes to coding, you mentioned it earlier, it used to be, here's your CPT, have a nice day. There really is a lot more detail that you need to go into with the codes. So you need to make sure that you understand not just what codes apply to your device or drug, whether that's the procedure code that's used for billing or the diagnosis code that's used for medical necessity edit, but the coding guidelines become an important feature in understanding code also, code first. And I know I go out to manufacturer sites all the time and I find these really handy reimbursement guidelines that can help providers adopt your technology and quickly and easily get reimbursed for it, but those need to be kept up to date. And they absolutely need to take into consideration things like those coding guidelines. After that, it's also important to think about which codes go together. So you might have a particular procedure which always requires a device to be reported with it. Well, which is the device code that goes with that procedure? Or you might have some hospital revenue code billing going on and you need to understand the crosswalk there. Or if you are simulating the cost of actually having a particular surgical episode, you might want to think about there's the procedure, and then there's also anesthesia and lab testing that always or typically goes along with that clinical scenario. And you want to sort of create that bigger picture of how your device or drug or biologic is actually used clinically, but also then what work ends up happening for the provider to submit the bill. Payment is an important factor. You did sort of mention that. We see every year a lot more complication happening with the status indicators on the outpatient side, as well as with multiple reductions happening on the physician side. So even once you have your CPT code, it's important to understand how it's paid. And if there are any special conditions where it is normally paid one way, so you looked it up in Addendum B and thought you were good to go, but it turns out that if it has one of those tricky Q status indicators or J status indicators, there may be clinical scenarios in which that reimbursement that was published in that payment file is quite different. And it's good to have a clear understanding of that so that you can properly communicate to providers. And then unfortunately, Medicare is complicated by geographic differences in reimbursement. So whether you're billing on the physician side and you need to understand the geographic location of that physician, or you're billing on the hospital side and you need to understand the specifics for that given provider, it is really important to have your handle on how will we or how will providers get reimbursed for this item and the services associated with it. Obviously, you're not going to be able to set your pricing strategy way higher than the Medicare published reimbursement rate for a given provider that you're walking in on. The MediReg coding suite provides calculators that will quickly show you that information. And we also have an inpatient DRG standalone grouper and calculator, which looks at almost exactly like what a provider will use when they send a bill. So it will let you group an inpatient stay into an assigned DRG and see the reimbursement rate for that given provider. That can be an exceptional tool to understand the ins and outs of the DRG grouping and see how certain clinical scenarios will group to different DRGs, and to make sure that you have that sort of bigger understanding. And I do just want to say, this is a little courtesy, that this year CMS has had a really hard time getting the grouper out and right. So they just published revision 3 of the DRG grouper, and they found significant errors that they were making. For instance, there was a way that they weren't counting 4 or more stents or vessels, and therefore not ever grouping to the highest weight DRG. And they fixed it. But that kind of indicates to me that maybe for 2 months they were getting it wrong, and it's a retroactive fix. It's just really important to stay on top of issuances coming out from Medicare that are specific to the services and product lines that you care about, and not just sort of trust that, well, if you read the final rule, you're good to go. And then also, I think that it's important to have a handle on coding guidelines that come out from other organizations that both payers and providers will reference during, say, for instance, an audit. So the American Medical Association publishes the CPT Assistant and the CPT Changes Insider's View. Both of those will have clinical scenarios or rationales for changes that can be very important to understanding what ends up becoming a payer edit later. And then also the American Hospital Association publishes the ICD-10 coding clinic. We don't see CMS answering deep, detailed ICD-10 coding and grouping questions. That's being shunted to the coding clinic team. So the only place right now on the market that you can get that sort of very esoteric and specific advice about given clinical scenarios is the ICD-10 coding clinic. And I think it would benefit manufacturers to not only have access to that, but to consider even submitting questions. That applies to providers as well. If you see something sort of not being paid in a way that seems reasonable, where the clinical data and then the actual payer edits don't seem to align, a question clarification in the coding clinic can become a primary point of reference for everybody in the industry, and so get everybody on the right track on that piece. I think that we can go back to you now.
Leon, I'll even expand on your slide here, number 19, on the availability of geographic specific payments.
Mm-hmm.
I've created more coding guides in my life than I'd like to admit. And on those coding guides, I think we all know that we always use the national average because that's what's referenced. But as you stated, both hospital and physician payment can vary. I've seen as much as 20%. So your DRG payment may be XYZ, but if you're selling to Stanford, it could be 20% higher than that, which can be a game changer. Same thing with physician payment, really understanding that locality. The national is a great reference, but if you really want to be effective in selling, you got to know your geographical specific payment.
So that's actually your 20% number. I might push back on you and say that there are cases where it's more. What we see with our DRG calculator and with the Affordable Care Act passing is that providers now have a number of extra variables that they need to consider that will deviate them from the national adjustment. So they have their readmissions adjustment factors. They have their HAC adjustment where they've had hospital-acquired conditions. There are lots of things that providers are in control of that may impact their payment one way or another, value-based purchasing being another. So what we see is manufacturers in their negotiations sort of holding hospitals accountable, like, I'm sorry that Medicare is paying you less, but that's because you have a problem with readmissions. That doesn't mean that our device shouldn't be reimbursed at the, paid for at the full price. So I think that those provider-specific variables on the inpatient side have actually gotten really complicated, and our tool has this fantastic little report card it will show you. I'm happy to do a demo. I don't think we have time today, but if anybody wants to see examples of that, I'm happy to show it.
Yep. Nope, I agree. Wide variance many times. So we have, let's see, just about 3 or 4 slides here with some additional resources that are available to you. These are in the public domain. We've provided the links. So if you are in DME, you need to be aware of the DME PDAC advisory articles. So go to the DME PDAC. That's where you can go to verify your codes. Should there be a change in coding, that's where they will publish it. The PDAC is a contractor. It's a third arm to CMS, but that is where you will get your CMS kind of HCPC coding. AHRQ, under the Effective Healthcare, they are publishing draft questions, draft reports, and you can impact now. Canary spends a lot of time trying to get those draft decisions out there. It's always good to know a policy or a report came out, but it's better to know when it was in draft and you could have impacted. We talked a little bit about the bulletins. Again, they're very difficult to do manually, but there's a lot of great information published in these manuals or these bulletins that significantly impact coverage, even if they never make it to that policy page. Notification of policy meetings. Again, talking about being proactive versus reactive. So Canary sends out alerts on the Blue Cross Blue Shield of Massachusetts, or Regents, example, will publish when they have their meetings. HCSC is very good about publishing draft. All of those things you need to be aware of. Some payers, such as Anthem, are very good about posting updates. Most are not, and you have to just kind of be on that website to know if something changed. MLN articles. Again, something that both MediRegs and Canary is tracking. They're not necessarily coverage, but can impact payment and access, especially if you have a pass-through payment or you're a skin substitute or a drug. Those are changing quarterly, and those MedLearn articles are important to be tracking. We talked about the draft policies. You do not get much time on those draft policies. So HCSC, although they're great about posting, they only give 2 weeks for you to submit comments. Technology assessment, HAYS, NICE, ECRI, used to be TEC, all of those we are tracking and will send alerts when they are available. The 2 bullet points here on page 23 are Medicare CMS resources that are available to you. The CUP.net can give you some data on hospital DRGs and stays. You can tie that back to what MediRegs offers. They do have utilization data as well. The physician supplier extract summary file gives some data on utilization by CPT code for physician. They don't necessarily make it easy to use or to analyze, but do know that they're out there. If you are on the reimbursement side, I say it's always important to also be aware of the regulatory side and track some of the FDA public meetings. They are not always meetings on just clear approval or not approval. They sometimes have what kind of outcomes is going to be required for this category of products. So very important to be teaming with your regulatory team as well. CMS has a website that you can pull their draft LCDs. Ray Ellen, I'll throw it back to you to give you a little bit more on MediRegs, and then we'll take the last 5-10 minutes and kind of wrap it up with some very specific other tools that they can have.
Okay, perfect. So did you think that it would be a good idea for me to actually log into MediRegs now, or do you want me to just speak to this slide?
I think just the slide.
I agree. Okay.
Yeah.
Yeah, so it would be really nice if this information was just, perfectly published exactly under the headings that you want it to be published under, but it turns out that Medicare publishes a vast amount of information that can impact your reimbursement strategy, whether you're the payer writing the medical policies or the provider trying to comply with them or the device manufacturer trying to use this to drive strategy for your product line. It's absolutely important that in addition to proactively staying on top of regulatory issuances like the final rule, you need to get a little bit deeper down in the woods. So the Medicare manuals and the Transmittals and the MLN materials that CMS publishes. The MLN materials are written at the provider level with the provider as the audience in mind. They're sometimes a little bit easier to understand and cut straight to the point, whereas the Transmittals and the Medicare manuals are more written for the payers and they go into a lot of history around when a particular change occurred and what the thinking was, and maybe that's just not that interesting. So I do like to really focus on the FAQs and the MLN materials when they're available. But it's also important to keep an eye on things like court cases, OIG actions, and decisions that are coming out from CMS and HHS. So if you're lucky and Medicare's weighed in and given clear guidance, they find that document and you adhere to it, that's great. But very often the rules that Medicare have published and the guidance is either vague or missing. And so I might read a passage and decide that looks like it should be something that's payable, and you might read that passage and have a disagreement with me on that. So that can create an appeals process that's a big administrative burden for both providers and for payers. It's very good to have access to published copies of previous decisions that have been made by CMS and HHS, because it may be that this vague rule created confusion for somebody else halfway across the country, and they've already taken it through the process, and you can rely on that decision to extrapolate to your particular situation. What I've noticed is that there may be a very clear decision, and then CMS doesn't take that opportunity to clarify the vague regulatory language that they published in the first place. So really the only place where you're going to get that good guidance is by reading the appeals decision. So I would encourage you to have access to that. And then I just want to talk about risk. It's important to keep an eye on what the Office of the Inspector General and other audit bodies are investigating in the industry, where their focus areas are, and to be really sure that you're not giving advice to providers that would put them out of compliance with government regulations. So your reimbursement guidelines need to be kept up to date, and you should be taking a look at audit reports and compliance program guidances and corporate integrity agreements coming out from the Office of the Inspector General if they relate to other companies or products similar to yours, just to make sure that you're not missing out on a gotcha moment that you want to prevent. So all of this is a tremendous amount of information, and I would be overwhelmed if I had just attended this webinar, but I'd like to say we do have some tools that can really serve you. On the MediReg side, we have a comprehensive library of coding, payment, regulatory decisions in the MACs, and as well as state laws and regs and the state Medicaid manuals. Now those can be included in a daily email alert, but if you're a specialty organization or a device manufacturer or a pharmaceutical company, you may not want to know about everything happening in the healthcare landscape. We can help you set up keyword searches for your product name, the condition that your product serves, the actual CPT and ICD codes that relate to your product, and that will filter out the MediReg news feed to be really precisely exactly what you need, and that's a free service that we provide once customers have signed up and subscribed. So we'll train you on how to set those alerts up, but we're also just happy to set some of those alerts up for you ourselves. And then Canary is going to fill in some of the gaps that MediReg has, because MediReg publishes government-issued information, Medicare, Medicaid, MAC. We add in CMS, AHA, and AMA content, but that still leaves a vast landscape of over 200 private and commercial payers. So this is where Patty's product, Canary Insights, really comes in. And Patty, I'll let you speak to that.
Sure. So really, MediRegs and Canary, as Raylan said, really very nicely complements each other. MediRegs has extensive Medicare and government library, but really then capturing that commercial, and we do also do the Medicare and Medicaid, but really expansive on that private payer policy. So here is just an example. You have here, you log in. We have software that searches over about 250 websites based on your customized CPT or brand name. We pull in those policies. You log on and you have access directly to those policies. You don't need to worry if your West Coast field person has it or the East Coast. It is all stored here at your fingertips. You have a secured login. All of the policies are here. We talked a lot about the alerts. These alerts go directly to your inbox, so you don't need to worry, in this example, if Blue Cross Blue Shield of Alabama changed their policy. Our software picks that up. We have an analyst that reviews it and then sends that alert to the pertinent customers. You can log in and it goes to your inbox, like I said, so you don't have to log in. But if you want to do a report that says what changes came in the last 12 months, you can put in a search date, and Canary will provide all of the alerts, again, specific to your technology that came within that time frame. We are not just about policies. We really are a comprehensive reimbursement resource. We have an extensive payer directory where you can log in, get the name of the medical director or the policy analyst or the pharmacy director, at Aetna with an email address. We have fee schedules, especially for Medicaid. You can click on Arizona Medicaid, and within 15 seconds, have that fee schedule for your specific CPT code. The calendar of events is very important. We put in the open door meetings. We put in pertinent policy meetings. We also put in FDA meetings, etc. Really trying to keep you aware of what you need to do to be successful in this changing coverage landscape. So in summary, the payer landscape, whether you're device, pharma, lab, diagnostic, it's changing. We talked about some of those changes. The big elephant in the room is the Blue Cross and the CMS, but as you heard, all the other payers are also undergoing significant change. Most of you are being asked to do more with less, and that really is where MediRegs and Canary Insights can help you. We have automated that process, so you don't need to be out looking at the different websites to know if something changed. We send out alerts, really making you first to know. Also, understanding what we talked about today with the new payment initiatives and payment methodology. How do you fit under that? That's going to tie to your coverage landscape. In summary, and I know we didn't have time for questions, but please submit them. Ray-Ellen and I will be in touch to make sure that you get your questions answered. And my contact information, and then also I think Ray-Ellen, yours will come out through MediRegs. So thank you very much for attending. Hopefully we covered a lot of information. Hopefully they're good tools for you to use. If you are interested in learning more about either MediRegs or Canary, please reach out to us. And we very much thank you for attending. Ray-Ellen, anything else that you want to add as we close out?
No, I think we covered it. The presentation slides were available, but I do want to point out that part of our webinar series at this time of year includes excellent webinars about the OPPS and the CPT changes for the upcoming year. And we didn't do an IPPS webinar, but we did the slide deck anyway. So if anyone needs access to a quick click-through overview of the big deal changes for 2017, I'm happy to share those slides with you. That might be another reason that you feel like reaching out, so that you can kind of quickly scan through and see if your specialty areas are being impacted and in what way.
Very much so. I have used that tool a lot, and it's a great resource to try to track all of those changes for 2017.
Yeah. Patty, thank you very much. I look forward to our next session. We'll be having some other real specific webinars next year about coverage related to particular specialties. That would be information that you would be able to glean if you had the coding suite and Canary Insights, but we're happy to provide those as courtesy educational webinar for our clients and contacts. So thanks for your time today, and have a great day.